Morning, everyone. I'm Matthew. I'm one of the PGY2s here at UBC. Thanks for joining me for my grand rounds and the last grand rounds of 2017. Last but hopefully not least. So my talk today is going to center on testosterone therapy, specifically in the context of something called late-onset hypogonadism, which is what we're going to go on to talk about today. These are the objectives for the talk. First, we're going to talk about what defines, or what we think defines, late-onset hypogonadism as a distinct clinical entity, and then we're going to review recent evidence on the efficacy of testosterone therapy and discuss some of the controversies and the evidence for and against these controversies, specifically as they relate to cardiovascular risk and venous thromboembolism risk. I purposely avoided talking about prostate cancer risk and the association with testosterone therapy today because there hasn't really been a lot of new evidence, and the current state of agreement seems to be that there's not much evidence at all for increased prostate cancer risk or increased risk of worsened prostate cancer with testosterone therapy, and it shouldn't be withheld on basis of fear of prostate cancer. Now, Ryan Flanagan did an excellent rounds on this about 3 years ago. So I was speaking to him, and he thought it would be a good idea to actually present this topic again. Although it is a short period of time, there has been quite a bit of new evidence which has come out, which has sort of added to the debate. So I'm going to be focusing on the recent evidence in the past about 3 years that's come out on this topic. So first we'll talk about late-onset hypogonadism and what it is. So it's a relatively new clinical entity, but at this point now there's multiple large population-based studies which have documented a gradual decrease in serum testosterone as a man ages. In terms of free testosterone, some studies have quoted it as 0.4% of a man's total serum testosterone per year, or 1.2% of free testosterone per year after about the age of 40. Other studies quote it as an absolute decrease of about 0.1 nanomoles per liter per year. Just to put into scope, the average, or the lower limit of normal in nanomoles per liter is 10.4. Now, I'll be flipping back and forth between nanomoles per liter and nanograms per deciliter, which is the American notation, just because a lot of the studies are American. I'll try to provide equivalencies as much as I can. So there have been, like I said, there have been a lot of population-level studies that have examined populations and men as they age over the course of 15, 20 years. These studies are things like the European Men's Aging Study, the Baltimore Longitudinal Study of Aging, and the Massachusetts Men's Aging Study. And I'll be referring back to these as we go along. So what is late-onset hypogonadism, which I'm going to call LOH just for ease of pronunciation? It seems to be a type of hypogonadism or low testosterone that functions along similar mechanisms as primary and secondary hypogonadism or testicular and pituitary hypogonadism, but it looks like it's a distinct clinical entity. There is elements of both involved, and we're not really sure about the exact mechanisms yet. But what we believe is that as a man ages, the testis ages as well, and its response to the gonadotropins FSH and LH is blunted as a man ages, so the testosterone response will be less. However, we don't see a concomitant rise in FSH and LH like we would expect in a normal response to a malfunctioning testis. And this blunting of the central response is likely due in part to accumulation of chronic disease as a man ages, and there may be other factors at play that we don't quite understand. So, just to rehash, primary hypogonadism is primary malfunction of the testis, so the failure at this level of the testis to respond to LH and FSH, particularly FSH, and to produce testosterone. Secondary or pituitary hypogonadism occurs at the level of the pituitary or the hypothalamus, and that's a failure of secretion of gonadotropins. So in terms of prevalence, as LOH is a bit of a new clinical entity, there's been varying definitions over time. One study, the Baltimore Longitudinal Study of Aging, had a definition of any testosterone less than 325 nanograms per deciliter, which is 11.4 nanomoles for the rest of us and the rest of the world. Any testosterone level below that was classified as hypogonadism, and they found very high numbers, 20 to 50% prevalence depending on how old an age cohort you are looking at. More on the other, yes?
Sorry, just a question.
Yeah.
So is that a total AM testosterone?
Yeah, so
one sample?
One sample, exactly. And we'll talk about this later, but the standard now is measurement of 2 levels to confirm, because as we know, testosterone levels can fluctuate quite a bit. But this is this one very large study's definition, which agreed is maybe not the greatest. And on the other end of the sort of stringency spectrum, the European Men's Aging Study, or EMAS, defined hypogonadism as a testosterone level less than 11 nanomoles per liter, and the presence of 3 specific sexual symptoms, which were decreased sexual desire, decreased morning erections, and decreased erections with arousal. And with those much more stringent criteria, they found a prevalence of about 2.1%. Again, these people also used a single measurement of testosterone.
But the Europeans always lie about stuff like that.
Yeah. I don't know. I'm not sure how to account for that.
Especially with Scots.
So there's actually a recent article in the BCMJ published by an endocrinologist who was the local expert here for this. He's since moved to the Middle East. But the clinical practice guideline that he published actually had some pretty good advice, I thought, and this was recommended to me by Ryan Flanagan, who was gracious enough to help me with this. And I think the current definition of LOH has sort of settled into this idea of being symptomatic with low testosterone, symptoms of which we'll cover later, having a measurable low testosterone, and having an improvement with supplementation of testosterone, or replacement of testosterone. So that's the general definition we're going to be working with today. So in terms of when to treat, we have guidelines from the Endocrine Society, which recommends treatment at a testosterone level of less than 10.4 or 300, depending on which system of units you're using, and the presence of symptoms. The EAU and the International Society of Andrology have guidelines saying you should treat below 12.1 with symptoms. Both of these guiding bodies also stipulate that you should have a second confirmatory measurement after the first, and both should be low, just to confirm that you're in fact measuring a true low. So I was talking a lot about symptoms and the symptoms that would indicate treatment. As you can see here, this is a list from a 2014 CUAJ piece on LOH. The symptoms are very vague and they're very varied. And so as a result, there is a lot of openness to interpretation on what you can determine as symptomatic low testosterone, which is maybe why you can sometimes find clinics in the States where you have a lot of bodybuilders with decreased libido and fatigue. So aside from just symptoms such as fatigue and low sexual desire, there has been a lot of literature now on other more serious comorbidities associated with low testosterone, and there's a lot of literature on this, and I won't be going through that in detail, but just a brief overview. And these are just numbers I picked out of random studies or other studies I've read. There's an association between low testosterone and metabolic syndrome with an odds ratio of 3 for testosterone less than 8. An all-cause mortality hazard ratio of 2, a mortality from cardiovascular disease of 1.2, and there's a lot of papers out there discussing increased sexual dysfunction, decreased energy and mobility, and decreased mood associated with low testosterone. Most of these studies, admittedly, were observational, and so the directionality of that is up to interpretation, but it's definitely something worth looking into, I think. So we're going to talk now about the evidence for treatment and the efficacy of testosterone therapy. Like I said, I'm going to be focusing on recent papers within the past 3 years or so, but prior to that, there's been a large body of literature on testosterone therapy and the benefits of it. I've just listed off a bunch of things that have been demonstrated in other studies before. There's decreasing in your fat mass, increase in lean body mass, decreasing in overall BMI, increase in bone mineral density, improved glycemic control and lipid control, improvements in mood, sexual dysfunction. So, there's a lot of evidence out there, a lot of it mixed in terms of magnitude of effect and whether or not there's effect at all, but there definitely seems to be something here. So this is the first trial I wanted to talk about, and this was probably the one that people in this sphere were most excited about. It's called the testosterone trials, and they were heralded as the definitive answer to whether or not testosterone was effective, and they're meant to be the silver bullet. It was designed as a 7-armed randomized controlled trial, meaning that the same population was enrolled in up to as many of the different arms as possible. There were 3 main arms that were studied, though, and that was sexual function, physical function, or mobility, and vitality, which is sort of energy levels and feeling of well-being. They had a total N of 790, but a lot of these patients were enrolled in multiple arms of the trial. The intervention in this study was testosterone gel administration with a target testosterone level of 500 to 800 nanograms per deciliter. The control was placebo, and the duration of the trial was 1 year. Inclusion criteria were men greater than 65 years old, men with an average testosterone of less than 275 across 2 measurements, and symptoms of decreased sexual function, physical function, or vitality. Now, in order to be enrolled in one of the 3 major arms, they had to meet pre-specified criteria for enrollment in the different arms. And men could be, again, enrolled in multiple different arms. Exclusion criteria were men with active prostate cancer or PIN, men with a prostate cancer risk calculator, risk of greater than 35%, or a risk of high-grade cancer greater than 7% on the PCRC, men who had a stroke or an MI in the past 3 months, or men who are hypertensive greater than 160 on 100 were excluded, and men with an IPSS of greater than 19, men with untreated OSA, and men on medications affecting their testosterone level were also excluded. So the sexual function arm of the trial was probably the most remarkable arm in terms of response. And their primary outcome was the score on question 4 of the Psychosexual Daily Questionnaire. Now, the PDQ is a validated measure of men's self-rated sexual and psychological well-being. The other studies which had used this in validated settings didn't do it the way that this trial did, where they only took 1 question and rated it. So I'm not really sure how that applies in terms of external validity here. This is question 4 here on the screen, and it asks you to rate yes or no answers on 12 different sexual activities and whether or not you've done them within the past day. And so the score out of 12 on that was the primary outcome for the sexual function. They also had secondary outcomes of sexual desire scores as based on scoring on a standardized interview, and IIEF, or International Index of Erectile Function scores. In terms of results, there was a significant increase in sexual activity. They measured a treatment effect of about 0.58 in the sexual function arm of the study. The treatment effect is roughly like can be interpreted as a percentage difference or percentage improvement. They also looked at this outcome in all patients, not just ones who were involved in the sexual function arm, and the treatment effect was similar, about 0.62. They found that patients had improved in erection scores with a treatment effect of about 2.6, but this was noted to be inferior to the treatment effect found commonly with phosphodiesterase 5 inhibitors. And finally, they found that patients on testosterone therapy did have an increased amount of sexual desire. In terms of the physical function arm, the primary outcome was a 50-meter improvement in the 6-minute walk test. And the reason they chose 50 meters was that this has been demonstrated in other studies to be the minimum clinically significant difference. Secondary outcomes were overall improvement in the 6-minute walk test and improvement in the PF10 score, which is basically a self-rated survey for mobility. Can you climb a flight of stairs, or can you walk up 2 blocks without feeling short of breath? So among the patients who were enrolled in the physical function trial, there was no difference in the walk test. So there was no improvement based on testosterone therapy. Then they extended the analysis to all patients, not just those with a physical function complaint, and they did find an improvement. There was an odds ratio of 1.76 for an increase of 50 meters or more in the 6-minute walk test. That translated to a mean improvement of 6.7 meters in the walk test. And they also found that on the surveys that patients filled out, the patients themselves noticed an improvement in their ability to walk, even though that wasn't borne out in the other studies. And the final main arm of the study was the vitality trial, which basically was looking at energy levels and mood. The primary outcome was a 4-point increase in this scale, which is the FACIT fatigue scale. Again, it's a patient survey where they fill out a Likert scale about how they feel in terms of energy. So questions like, I feel fatigued, I feel weak, I feel tired. This is an externally validated tool as well. And secondary outcomes were the short form 36 questionnaire, the positive and negative affect scale, and the PHQ-9 depression screen. Again, all just different questionnaires to rate mood and energy levels. They didn't find any improvement in the fatigue score on this study. There were small improvements in affect and depression scores, and patients were more likely to report better energy levels. And this is just a quick survey of the 4 other arms. Again, there were 7. There were 3 main ones, but these were the 4 other arms. They studied anemia and hemoglobin levels, and the outcome was a 10-point increase in hemoglobin. 54% of those on testosterone had a 10-point increase versus 15% in the placebo arm for anemia without a known cause. In men with anemia of a known cause, there was also a very similar increase in testosterone. They also looked at bone density, and of men on testosterone therapy, there was a notable, or a statistically significant increase in bone mineral density and simulated bone strength. The treatment effects for these, though, were quite minimal, 0.07, 0.085 for simulated strength. So even though they were significant, they're relatively minor in terms of overall effect. They looked at cognitive function. There was no improvement. And they also measured coronary artery plaques with coronary CT scans. They did find a significant increase in the amount of the thickness of non-calcified plaque in men who were receiving testosterone, but the clinical significance of this is unclear at this point. And then other information to come out, not necessarily new studies, but new meta-analyses. This is one that was published last month in the BMJ Open. This meta-analysis compiled 70 different RCTs and 19 non-randomized studies. And the comment from the authors was that most were at high or unclear risk of bias. So, as Dr. Gleave likes to say, garbage in, garbage out, but we'll do what we can with the information. The median treatment duration for patients in this study was 6 months. The outcomes that they followed were quality of life, depression scores, libido, erectile function, and activities of daily living. They followed adverse events as well, which were cardiovascular events, prostate cancer, and erythrocytosis. They examined the efficacy of testosterone as a class against placebo, as well as they attempted to tease apart the different testosterone modalities and see if there was a superior route of administration. So they noted a quality of life improvement. They measured their treatment effects in terms of standard mean differences. The numbers here you see just for scale, an SMD of 0.2 is considered a small effect, 0.5 is a moderate effect, and 0.8 is a large effect. So on average, men noticed a subjective improvement in their quality of life. They noticed a subjective improvement in their depression or in their mood. They noticed improved libido and improved erectile function. As you can see, though, the treatment effects for these are all somewhat small, in the range of 0.2 to 0.3. And finally, there was no difference in cardiovascular events or prostate cancer. So here are some of the forest plots from this meta-analysis. This is for quality of life. As you can see, there is a clear favoring towards people on testosterone therapy for quality of life, but the effect is relatively small. And this is the forest plot for cardiovascular events. You can see it does cross the line, so it's a non-significant difference. However, there is a clear trend towards increased cardiovascular events in men on testosterone, which is interesting. And so this RCT, this meta-analysis compiled 16 RCTs, based on, and it came out of China. Median treatment duration was 6 months for these men. Their outcomes were score on the Aging Men's Symptom Scale, which is a validated questionnaire for symptoms of aging in older men. They also looked at BMI, total weight. They looked at lean body mass and fat mass, as well as total cholesterol. This is the Aging Men's Questionnaire, which the next two meta-analyses refer to. As you can see, it's another survey of sort of subjective symptoms: sleep problems, sweating, nervousness, anxiety, fatigue. So this meta-analysis did note a significant improvement in the AMS score, which is all these negative symptoms associated with aging. However, the overall improvement was small, 1.7 out of 85 total points. They did notice an increase in lean body mass in men who were on testosterone, on average about 1.2 kilograms. There was no decrease in weight or BMI. There was no change in bone mineral density. They did notice a small decrease in total cholesterol, 0.16 milligrams per deciliter. There was no significant difference in PSA score or IPSS score, or in PSA level or IPSS score. And this is the final meta-analysis I wanted to look at in terms of efficacy, published in the journal Andrologia. It's a study again out of China, which only looked at 5 RCTs, but specifically ones incorporating that Aging Men's Symptom Score that I showed earlier. They found that there was a significant decrease in score of symptoms, but again, the total effect was relatively small, 3 points out of a total of 85. So in summary, what does the new data show us on the efficacy of testosterone therapy? Across multiple studies, there seems to be evidence of improvement in several domains, particularly sexual function, mood, quality of life, and lean body mass. However, overall, the effects are probably mild in nature. There is some more questionable evidence for improvement in BMI and bone mineral density. This sort of fits in with previous literature, which had shown mild improvements in multiple domains. When testosterone replacement first came out, everyone thought it was going to be a magic bullet, and every man over the age of 65 was going to be feeling amazing and weighing 180 pounds, but a muscle. But it seems that the benefits have been a bit more modest than we initially thought, or than were initially thought. So next, I want to talk about some of the controversies surrounding testosterone therapy. The FDA published several warnings in 2014 and 2015 with regards to testosterone therapy. They published warnings about possible risk of venous thromboembolism, as well as increased risk of heart attack and stroke. And they also stipulated that there was no good evidence for the benefit of testosterone therapy. These warnings were in large part based on several studies which came out in the early 2010s, which showed some evidence of risk associated with testosterone therapy. Perhaps the first one to really raise the red flag was this by Basaria and colleagues. It was a study designed to test effects of testosterone on mobility, but it was stopped early because of a significant increase in adverse cardiovascular events. It wasn't designed or powered to look for cardiovascular outcomes, but the fact that it had a significant worsening in risk sort of caused people to look into it further. So this was a study by Vegan and colleagues, which was a retrospective observational study. So this study pulled patients from a pool of men who were receiving angiography, so who had at baseline increased cardiovascular risk. They found a significant increase in risk in men who had been receiving testosterone therapy in terms of cardiovascular events like myocardial infarction and stroke. Interestingly, before they did their multivariate adjustment for variables, the risk actually favored the testosterone therapy group by a factor of 2. Interestingly as well, 9% of the sample in this study was eventually found to be female. And they identified their treatment group not necessarily by actual reception of testosterone, but simply by prescription. So any man who received a prescription for testosterone was deemed to be treated with testosterone. There was no measuring of testosterone levels or confirmation of whether or not patients were actually taking it.
How was the female?
I'm not sure. They didn't really discuss that. That was something that sort of came up in criticisms after the study came out, that people who looked at the data set said these patients are female. I'm not sure why. This is an.
Is there any indication for women to get testosterone?
No, I wonder. This is probably.
Transgender.
Oh yeah, maybe possibly yeah, or they were pulling the control groups out of women who had shown up for angiography. This is another study by Finkel et al., which showed an increased risk of myocardial infarction. Again, this study had some methodological question marks about it. Patients were self-controlled, so they compared heart attack in the 6 months prior to initiation of testosterone to rates of heart attack in the 90 days after initiation of testosterone. And again, they only identified patients by prescription of testosterone. So again, some methodological question marks about this one. So just for scope, those are the studies that sort of engendered the whole controversy, which led to the FDA placing a warning on these products. So I would like to talk about now the recent evidence with regards to cardiovascular risk associated with testosterone. So this study by Cheatham was a retrospective cohort study with an N of about 44,000. Their inclusion criteria were men with a testosterone level of less than 300 or a coded diagnosis in the EMR of hypogonadism. They excluded men with active testis and prostate cancer, AIS, Klinefelter's, and pituitary disorders. Their main outcome was a composite cardiovascular event outcome composed of a myocardial infarction, coronary revascularization, a stroke or a TIA, new unstable angina, or a death which was ruled sudden cardiac death. So in men who had ever received testosterone, they did not differentiate between current testosterone recipients versus previous testosterone recipients. There were 8,800 men who had ever filled a testosterone prescription. They were followed for 3 to 4 years, depending on whether or not they received treatment. And baseline testosterone in those on treatment increased from about 212 to 318. And of note, that is still below the target threshold. Usually we target level targets are greater than about 500. So they found an event rate of their composite cardiovascular outcome of 10.2% in the untreated population versus 8.2% in the treated population over this period of study. So that's a hazard ratio of about 0.67, which was significant. So this study appeared to show that testosterone therapy was in fact protective against cardiovascular events. This next one by Wallace et al. Came from Toronto and was a matched retrospective cohort study, approximately 40,000 patients, 66 years or older. The treatment group was men receiving any sort of testosterone therapy, and unfortunately this study wasn't able to actually test testosterone levels or ascertain whether or not men were receiving testosterone. They simply looked at prescription records. Their outcomes were mortality, cardiovascular events such as MI, stroke, or venous thromboembolism, and a new diagnosis of prostate cancer. So they noted a mortality benefit overall with treatment with a hazard ratio of 0.88, which was significant. There was no difference in this study between testosterone and no testosterone in terms of cardiovascular events. They also went a step further and they stratified patients based on the duration of total exposure to testosterone. They actually found something interesting in that men who had received short doses of testosterone, so in median 2 months, actually had an increased risk of mortality and cardiovascular events, which was something that no other study had found. The middle and upper tertiles of testosterone exposure all had decreased or improvement in these metrics. And there's some speculation in the paper about why this is, or if it's just spurious data, but I thought this was an interesting finding. This paper by Sharma et al. Was a retrospective veterans cohort study with 91,000 patients. And they included men with a single low testosterone value. And they didn't define their own criteria, they just went by lab criteria depending on which lab was testing it, they went by that lab's lower limit of normal. They excluded patients, again, with MIs or strokes, or patients whose testosterone was spontaneously normalized before treatment. Again, they looked at MI, stroke, and mortality incidence. They stratified their patients into 3 groups: the untreated group, the group who received testosterone treatment but whose testosterone did not rise to normal levels, and then they also examined men who were treated and whose testosterone rose to treatment levels. And of the people whose testosterone adequately responded to therapy, there was a hazard ratio of 0.44 for mortality, which you can see here in this graph. In terms of MI risk, untreated or people who were treated had a hazard ratio of 0.76 for myocardial infarction against people who were untreated.
How would you interpret that?
Yeah, so I noticed this as well. It seems to be very little separation until about 12 years of follow-up, in which point there is a pretty sudden dip. The discussion in this paper didn't really mention it too much.
The hazard ratio is relative.
Yes.
Right?
Mm-hmm.
Absolute necessary.
Yeah. It would.
It's just an odd Kaplan-Meier
Mm-hmm.
to get a hazard ratio like that.
Yeah.
Generated all in the last.
Yeah.
Presumably, sure, so you have to know what the median follow-up is too. Because how many people are out at 12 or 14 years?
Mm-hmm.
Where's the bulk of the people?
Yeah.
Numbers.
Yeah, median follow-up is 4.7 years, 6.2 years. So, yeah.
How can you?
Yeah, how can you? I agree.
It's driven by very few people.
Mm-hmm.
It's only 32 people in the untreated arm.
Yeah.
What journal is this in?
This is the European Society of Cardiology, or European Heart Journal. And again, this is just a rehash of the prior meta-analysis that came out earlier this year, which again showed no significant difference in cardiovascular events. So in summary, with regards to cardiovascular risk, there are multiple studies now which show a statistically significant mortality benefit to testosterone therapy. And at worst, it appears that the event rate for cardiovascular morbidities is similar, and several studies actually show a protective effect as well. And so finally, we're going to talk about the venous thromboembolism risk associated with testosterone therapy. This is a study published in Chest by Sharma and colleagues, which is a retrospective cohort study with an N of about 70,000. The inclusion criteria were too low testosterone levels. Excluded were people with a history of VTE, people on warfarin, people with active cancer or coagulopathy. They stratified their patients into 3 groups. There was the group who was treated and had an adequate response, the group who was treated and did not have an adequate testosterone response, and the untreated group. And they did not find a significant difference in incidence of VTE over the follow-up period. And this study by Martinez et al. Was also a retrospective case control with approximately 900,000. So what this was a registry study of family practices in the UK, and they scanned the databases for people who had had a VTE, defined as a DVT or a PE, and then they matched up to 50 healthy control or non-VTE controls to these patients. Their stratification arms were patients who were on current testosterone therapy with a total duration of less than 6 months or a total duration of more than 6 months, patients who had had testosterone therapy within 2 years, and patients who had not had testosterone within the past 2 years. Interestingly, they found that within the first 6 months of testosterone initiation, there was a risk ratio of about 1.63 for venous thromboembolism. After 6 months, though, that risk dropped back to baseline, and there was no significant difference. I took a look in the paper at the actual numbers because I wanted to see what the absolute effects were. So of people who had VTEs, there were 69. So of the 19,000 VTEs that there were, 69 occurred in people who were on testosterone therapy, which is about 0.3%, 3.4% of all VTEs occurred while on testosterone. Of about approximately 2,000 testosterone users, 91 of those developed a PE or a VTE within 2 years of their testosterone therapy, which is 4%, which is somewhat more significant. And finally, this is some data which kind of comes to us from Ryan Flanagan and Jen Locke. This is an abstract that they submitted to the AUA and that they've been kind enough to share their data with me. This is a study of BC patients and is a cohort case control study. And this found 40,000 testosterone users, and in that group there were 135 PEs. From their analysis of the data, there didn't appear to be any association between testosterone and PE, and this was regardless of the duration of exposure and regardless of testosterone level at entry. So in summary, with regards to VTE, there does appear to be some conflict in terms of recent literature. If there is an increase in risk of VTE with testosterone therapy, it appears that the absolute increases in overall risk are likely still low, but possibly still significant, and we need to look more into this. So in summary, for testosterone therapy, what we found is there's likely some mild to modest benefits in terms of sexual function, quality of life, and how a patient feels. There is more and more evidence now that there's a mortality benefit. At worst, there's no increase in cardiovascular risk on testosterone therapy, or there may even be a protective effect. And there may be an increase in VTE risk, but it looks like this may be low overall. So these are guidelines published by some of the major bodies, the EAU, AUA, and the Endocrine Society. And in summary, all of them recommend testosterone therapy in men who have measured low testosterone and who are symptomatic. And I think that is appropriate given the evidence that we reviewed today. So I'd like to say thanks for listening to my presentation, and thanks to Ryan, Dr. Goldenberg, and to Jen for your help. Couldn't have done it without you guys. And this is my references. Thank you.